All right, I show about a minute or so after, so we're going to go ahead and get ourselves started. We may have others join us. We definitely have more coming into the waiting room as we speak. Let me extend a warm welcome to all to this fifth session out of 7 in our 2021 through 2022 CEO CFO Leadership Institute. Our session today on revenue cycle basics for FQHCs. We're excited to have our very own Javine Williams as our facilitator today, and we'll introduce her more fully, or reintroduce her to most of you more fully in just a moment. Just as a reminder, my name is Gerard Jolly. I am the Director of Career Advancement Strategies here at NAC. Let's see here if I can get the slides to advance for me. There we are. As you note, our meeting is being recorded today. Please feel free to be actively engaged, both in the chat as well as verbally. While you prepare to do that, though, we do ask that you keep yourself on mute if you're not speaking or participating in that discussion. You can find the slides for this session in your calendar appointment for this meeting. All right, so with that said, today our facilitator for our discussion is my colleague and friend, Javine Williams. She is our Director of Finance Training and Technical Assistance at NAC. And Javine's previously served as NAC's Director of Business Support and Finance. Before she came to NAC, she was the VP of Consulting for PMG Incorporated and the CFO at Samuel Rogers Health Center. She's also served as CFO for Shawnee Mission Physicians Group and is manager of accounting, payroll, and medical records for St. Luke's Shawnee Mission Health System South. Javine has worked in the field of public accounting at the national firm Baird, Kurtz, and Dobson, or BKD, as they're also known. We're excited to have Javine with us, so without further ado, I'll turn it over to Javine.
Well, thank you so much, Gerard, and welcome everyone to the session today. I hope that it will be very informative. Let me see, my mouse is being kind of tricky on me today. Okay, so here's what we're going to talk about today, just a very high level of what the revenue cycle. We're going to go into FQHC Medicare and what that means, you know, what the PPS FQHC Medicare rate means. And then we're going to touch on telehealth during the public health emergency. So to start off with, for revenue cycle, the one thing about revenue cycle is it's constantly work. You have to constantly make sure you update your policies and procedures and train your staff on an ongoing basis, because once you fix something one day, something else is going to need to be fixed the next day. So here, let's talk about the journey of data. So looking at the bottom of the screen, you know, data, you know, everyone wants to want data. It's like, we want more information, more data. But data really doesn't tell you anything. So looking at the bottom of the slide, yes, the numbers, 99213, 635, 250.02. These are all information, but it really doesn't tell you anything. So what you want to do is to go from just having data my transitions. See, my transitions. Oh, okay, there we go. You want to go from data, take the data and change it into information. So a 99213, that's an office visit. But just having a 99213 without the definition of office visit, it really doesn't tell you anything. But once you take the data and then you make it informative, then you can be knowledgeable and make real management decisions based on the data you make. So whatever you do around the revenue cycle, it's going to be a lot of numbers, but you need to change it from numbers to actual knowledge so you can actually make management decisions based on the information you're pulling out of your systems. Sorry about the jumping of the slides. I'll get this down here in a second. So it all starts when a patient inquires for services at your health center. So that's when your whole revenue cycle starts. So you need to have things in place when a patient schedules a visit to maximize your reimbursement, to get those data elements as many times as possible. Because since with revenue cycle, as many times as you verify the information, the cleaner it's going to be. So start verifying the information when they're making the appointment, and then verifying that each individual times you can from when a patient checks in to make sure you have the most accurate, up-to-date information. Okay, so revenue cycle management and patient flow, they all work together. And the one thing I say, you know, it's all about the patient experience. So don't make your patient flow, don't make your patient flow about the revenue cycle, make it about the patient. So don't have your, and Gerard, you might be clicking the slides and then hitting on the on the monitor. So you don't want your patient to have to work around your revenue cycle management process. I did a revenue cycle assessment for a health center, and they had the patient go to the front desk to check in, then go to a separate place in order to pay their copay, because they didn't want all the front desk people to have cash, so they had a cashier. So the patient would have to go from the front desk, then to the cashier before they go to the visit. Well, you know, it was internal controls that made sense, but from a patient flow, it made no sense at all. It's like, have the patient pay right there at the front desk. So it's different things like that with your revenue cycle, to have the patient in mind, to make sure that the experience is good for them. Because if the experience is good for them, they'll be more likely, more willing to pay. Okay, so a lot of people say, well, revenue cycle, it's just about sending out claims to your third-party provider. No, it's like, these are just some of the steps in the revenue cycle. So this shows how complicated, and if every one of these steps, if something is wrong, then you're gonna have a denied claim. So you need to look at all the different steps of the revenue cycle, and then have all the people and the tools and resources for your people to do, and the culture to say, this isn't just the billing department, the back office, this is the front office, this is the clinical staff, this is operations. Everyone has a responsibility in a revenue cycle. And you should have cross-divisional meetings with your team to go over all these different areas for revenue cycle. So what is your highest priority in keeping your revenue cycle going? And, you know, and this could change. You know, you might have a new contract, so you need to make sure you have all the edits in place for the new contract. So that's going to be a priority for that first month. But then after that contract is put in place and you have all the correct edits, you're going to have a different priority. But it's a moving target, but you need to make sure what that target is and what your goal is, what you're trying to do in order to clean up the process. But in all these different steps in the revenue cycle, someone needs to own that step and needs to make sure that the process you have in place really gets the end result that you're looking for. And I like to use this for verifying benefits. So a lot of vendors, practice management systems, there's other third-party vendors that say, yes, we will verify if that patient insurance is valid. But my question to that vendor is, how are you validating if that insurance is valid? Are you checking for medical, and are you checking for behavioral health? Because depending on the coverage, it could be different. Are you checking for dental? So they could give you a report and saying, yes, that insurance that this patient's insurance is valid, but what is it valid for? So I said all that to say is making sure that whatever you have in place, if you think you have an insurance verification process in place, checking it out and make sure that it's verifying it the way that you need for it to be verified. And I hope that makes sense. Okay, so best practices with appointment scheduling. This is, as I said before, the start of the revenue cycle process. This should be your pre-registration process. Get as much information from that patient, you know, before they actually come in for the visit. Getting that insurance information and putting it into your practice management field. If you're Medicaid, if you're a state Medicaid program, if their member ID is alphanumeric, it's like two alpha numbers, two numbers, then an alphabet, and then numbers. Code your practice management system so that it would only accept it in that format if you know that. So do things, you know, as much automated as you can in order to make sure the process is valid. And then When you're scheduling this, make sure that you let the patient know that their co-payment or their sliding fee is expected at the time of payment. And then, if you can give them that amount, that is great. And I'm a totally component of a flat rate sliding fee so that you can tell that patient right up front exactly how much they will have to pay. So in that scheduling thing, get as much information as you can as possible so you can verify with that patient. Let's see if I can go back. Okay, so another thing with scheduling in the desired patient time. If it's a month wait for your patient to get an appointment, they're probably going to be a no-show because they're probably going to end up going someplace else. So schedule an appointment that's an favorable time for that patient so that they can come in. Let the patient know what they need to bring in ahead of time, and then language count. Make sure that the community that you're serving, that you're serving them in the language and the cultural competency way in order to meet them where they are. Okay, some best practices for scheduling. When confirming an appointment. Now, I know a lot of health centers now are using text to confirm patient appointments. And that is great because especially millennials, they like the text messages. The only caution with text message confirmation is, making sure that you get the patient's consent to receive that text message for confirmation. But whatever way you're confirming it, just let the patients know that, we had this time dedicated, especially for you, and it's important for you to keep that time. Just saying, if you can't make it, that's okay. Just saying that time isn't important. So it's just using the right languages. And I always, strongly encourage scripts as possible for your front desk, your scheduling staff, and your billing staff because certain things you talk to all your patients about. Have a script to say, this is what you say when you're confirming an appointment. This is what you say when you're booking an appointment, so that it's very scripted and very monitored. Okay, so best practices for the actual encounter for the visit. So this is the actual face-to-face encounter for the visit. So first, reasonable and timely access. If your patient flow time is 2 hours, meaning from the time a patient checks in, it takes them 2 hours to check out, that's not reasonable access for care. Waiting 2.5 hours for an appointment is kind of excessive. So first, make sure you have reasonable access for care. And then complete clinical services. I know almost 90% of the health centers are patient-centered medical homes, but are you actually having that true integrated care? Making sure that when that patient is in, is their behavioral health needs being met? Are their dental health needs being met? Because once you have that patient there, just give that complete services. And then this is something with your providers, thoroughly and accurately clinically document everything that you do for that patient in a timely fashion. If it's taking your doc 2 weeks after the appointment for them to close the chart, that is an issue. Not only is it a financial issue, but it's a quality issue as well. Okay, coding and documentation on charts. The CFO, the CEO, the COO, and the medical director should be all together lockstep, and they should clearly hold providers accountable for signing off on charts. This is something that I see across the country that is an issue. And it's not all providers, it's normally a couple of chronic providers. And I always tell, when CFOs are having problems with certain providers closing charts, I say, look at some of the charts that the provider has open and then print it out. And then after he closes the chart, print out the chart after he closes it out and tell them to look at the difference. It's like, you didn't change it, because 9 times out of 10, they're not changing any documentation. It's like, so why did it take you so long to close this chart? This is a serious quality issue. So if you don't have a policy in place on holding providers responsible for closing charts in a timely fashion, you need to get a policy in place and with some teeth in it to hold them accountable. Because one of the biggest things with closing financials is getting the charts closed, then closing out the encounters and doing that whole reconciliation. So save yourself the time and make sure that they close them throughout the month as opposed to waiting to the end of the month. So that's something I've seen before. Okay, And also just making sure that you have the proper coding and documentation in your practice management system. Who's on your team responsible for when codes are changed, either sunsetted or new codes are added? Whose responsibility is to put the code in your system or to take those codes out and set that dollar amount for that charge? That needs to be someone's responsibility. And they need to look at that at least annually because the codes are updated at least once a year. Okay, charge processing. So this is, actually process, the provider, the patient came in, the provider closed the chart. Now you got to close the batches out and send them out to your third party through your clearinghouse. So what's your practice? What's your process for that? So today is March 8th. How do you verify that all the claims, all the visits that you saw on March 8th were actually processed and sent through? How do you know that day is closed? You need to have something in place to say, when every patient seen on this day, the claims have been processed and that day is closed so far as processing. How do you know you're not leaving money on the table? That's just something I put out there for you guys a little nugget to think about, to say, it's March 8th. You guys are probably in the process of going through your month-end closing time. So in February, how many open claims do you have in February that weren't closed? And that could just be a very good sign to show if that's an issue. Okay, and then using your software. So you have your practice management system edit, and then you have your clearinghouse edit. Make sure you have all those edits in place, because this gives you a chance to clean those claims before they get to the third party, and making sure you set that up. It takes time to set it up, but once you set it up, it saves you time on the back end. And then just making sure you're doing a reconciliation at the end of the month to make sure that everything is posted and processed. Okay, and start with the end in mind. So I love the Institute of Health have a Plan, Do, Study Act. This is a process improvement, kind of like a Lean Six Sigma, in order to improve processes. And I love doing this, around different things in finance, but especially around revenue cycle, because you can pick one key performance indicator. It's like we're going to do a PDSA around this to improve this indicator. But just know what you're measuring with and know what you wanted, how you want to improve with the end in mind. Okay, so best practices claim submission. Make sure that they're complete and accurate, and that it goes almost everything electronically. There are some situations when you're building secondary payers, you have to drop the paper. And then getting statements out to patients in a timely fashion. So putting the claims out there, getting it processed, and getting the statements out to the patients in a timely fashion. Okay, payment processing. This is a big thing. So almost everyone's processing their claims electronically, but I still have some health centers that are actually manually posting their payments. So I highly encourage you to look at what I would definitely say your Medicaid and your Medicare and your top commercial. Those are three payers that you should make sure you set up to process your payments electronically. That's just going to save you a lot of time. And then as you go through, add on other payers. But it just makes it easier for reconciliation. And also, you want to make sure your payments post, because if you're not posting your payments in a timely fashion, your billers could be working on a claim that you actually already had the payment for, but it hasn't been the payments haven't been processed. So a PDSA measure is have all payments or denials processed within 24 hours of receipt. And that way, you're not working on claims that you've already received payment for. Okay. So AR follow-up. So process denials and follow-up within a week of rejection. There has to be some kind of follow-up for denied claims, and it needs to be scheduled. So whoever in your billing staff, I like to be very deliberate and intentional. I would say whoever is responsible for denied claim follow-up, they should have a block on their schedule that's all they do from 9 o'clock in the morning to 12 o'clock every Friday is to do follow-up on denial claims. Because if you don't carve out time and say, this is what you're going to do for all this time, they're going to be constantly spinning their wheels because there's always something to do. But if you say, I'm going to work denial claims from 9 to 12, I'm going to post payments from 12 to 2, and then I'm going to do calls to patients from 2 to 4. If you have that schedule, then you're going to see headway because it's going to be very deliberate and very targeted and focused, and you won't get lost in the weeds and like get caught up on answering the phone, helping with the front desk, and doing things that we know all billing staff are kind of pulled into. So we're going to have our first polling question, and let's see if I can launch this poll. So I'm trying to launch the poll, but if I don't launch the poll, you can just actually put it in the chat. What do you think would be a good PDSA cycle around the revenue cycle at your health center? I don't think the poll came up, but you can actually just put it in the chat, your response on what could be a good PDSA cycle at your health center. So I do a revenue cycle learning collaborative where we have front office and billing officers come and go through a 6-month program where they do a PDSA cycle in order to improve their revenue cycle performance. And these are a couple of things that they picked to do on their revenue cycle. And thanks so much for the messages in the chat. Let me see what we have. Yeah, these clean payment posting. That would be a great PDSA cycle because, just posting a payment is more than that. Making sure if it's an underpayment, flagging that so you can follow up either with the insurance company or with the patient. So clean payment posting, I love that. Denials, definitely. Denial management is huge. Point of service collections and insurance verification ahead of services. So I like that point of service collections. So one thing to do a quick and dirty point of service collection for your front office staff, just say that, say we have 20 patients coming in, you should collect at least $10 from every patient. That's just a loose benchmark. And at the end of the day, balance out, what do we collect? How many patients? And divide by how many patients? That's a quick and dirty way you can see that if you're up for a collection, it's struggling or isn't good. Thank you. Thanks for all that feedback. I appreciate that. But there's so many different things you can do that. But if you can pick one, improve on that, and move down to another one. Great. Okay, let me close this. Okay, so that's just a big overview of the revenue cycle process from scheduling the appointment into actual posting the payments and doing AR follow-up. Now I'm going to talk about FQHC Medicare. So I want to first of all say FQHC is a Medicare designation. It is not a BIPIC or HRSA requirement. This is from the Center of Medicaid and Medicaid designation for reimbursement. So for health centers, that's why you have the FQHC Medicare PPS reimbursement. So what makes it unique? So we get, regardless of what we code, what kind of office visit, we get our same face-to-face core provider rate for Medicare. And that's why it's unique. But even though we get the same reimbursement, it's still very important for us to code for everything that we do. Okay, so a core provider for Medicare. So you get your Medicare PPS reimbursement for any face-to-face with any of these core providers, MD, DO, physician assistant, midwife, nurse practitioner, clinical psychologist, clinical social worker, and diabetic educator. Now, for there are some nuances, like with the certified diabetic educator. There's some national certification they have to have, but you can still get that Medicare PPS rate for all these different providers. And this is for Medicare. For some Medicaid programs, some RNs are included, but for Medicare, they are not included unless there could be a certified diabetic educator. Okay. So with FQHC Medicare rate, first of all, for preventative visits, it's all covered, so it's no out of pocket. But then you don't have the excuse me. So all the preventive visits, the annual wellness visits, the initial visit to Medicare, and you get an additional 34% increased reimbursement for those. We have some great resources on doing annual wellness visits, so I highly encourage you guys, if you're not doing those annual wellness visits, that's definitely money on the table, and just reach out to me and I can give you some of the resources. Our Elevate platform actually did a webinar today on how you can do those annual wellness visits. Okay, so you get the typical, I need to update the encounter rate for 2022 because we are in 2022 now, because I have the 2021 rate, which down there is 176.45. So that's the base rate. But then you have a geographic adjustment factor, depending on where you are, to get your Medicare PPS encounter rate. So each year, Medicare updates the fee schedule based on the FQAC market basket. So this is part of the Affordable Care Act. So we have the normal Medicare fee-for-service schedule is updated by the Medicare economic index factor. But for the Affordable Care Act, they had a separate basket for FQACs so that our fee schedule will be updated by our own market basket. And for the first time since this has been put in place in 2014, they're the same. The FQAC market basket has always been higher than the Medicare economic index factor. And for the first year, and this has to be pandemic related because this has never happened. We normally get a bump a little bit higher. So this rate, when I saw this raised my concern. I was like, if the Medicare economic index factor is increasing and our market basket is not increasing, what's going on with our cost report? Something might be going on. So that's one of the projects I'm going to start working on, because our costs are always more higher than fee-for-service Medicare providers, because we provide more comprehensive services. So I went off on a tangent there, but anyway, our rate is adjusted for our own Medicare basket. So make sure you're filling out your Medicare cost report as accurately as possible. I talked about this. This is your initial visit to Medicare, where you'll get that increased new patient reimbursement. These are something you can do for the patient. And then the annual wellness visits. This is the IPPE is only done the first time, but the annual wellness visit can be done once a year. And this is pretty much doing a comprehensive, kind of like a care plan for your patients. Okay, so encounter rate, make sure you code everything you do. There are some carve-outs. So immunizations and vaccines are reimbursed via the cost report. And then you have some labs and some ancillary, like x-rays, can be billed to, the technical component can be billed to Medicare Part B. And then you have your Medicare wraparound payment. So if you have a Medicare Advantage plan and you don't get your PPS rate with that negotiated contract, you can have a wraparound payment from your Medicare administrator contractor to make you whole to your PPS rate. So those are a couple of different things. So this shows how complicated things are. You can have, you can see a patient, you can have to bill Medicare Part A, Medicare Part B, Medicare Part C, and Medicare Part D. So health center reimbursement is complicated, to say the least. Okay, so here's a couple of different formats. So for Medicare Part A, that's where we get our Medicare PPS rate, and we use an institutional form. This is a form that's typically used by hospitals. So that's what we're kind of like a hybrid between a hospital and a physician office. We're a combination of both. So we use the institutional form. We use the revenue code 521 for medical visits, or 900 for behavioral health code. And Medicare will pay us 80% of our PPS, our calculated PPS rate, or our G code charge, whichever is less. So that's why you need to make sure, and I'll talk about this a little bit later on setting your G code, making sure that you're using a sound methodology and setting your G code so that you're maximizing reimbursement. So that's what the Medicare Part A. On Medicare Part B, on the right side of this this is for things that are outside of your face-to-face encounter with your provider. So that's your technical component for your x-rays or your labs. So, and if you're doing any hospital billing, that needs to be carved out from your Medicare PPS rate. So if you have a provider that's seeing patients in the hospital and also seeing patients in the health centers, then it should be carved out from your Medicare cost report, and that provider should be covered by different services, because those hospital services aren't covered by the Medicare FQAC rate. Okay, so here right now, some of the different revenue codes that you can use on your institutional form. The most common one is 521, is just a clinical visit, or 519 is for a Medicare Advantage plan. Okay, so I talked about G codes. So for FQACs, when you bill, you have to have a couple of different things on your claim forms. I talked about the revenue codes, 521 or 900, 521 for a medical visit, 900 for a behavioral health visit. You have to have the revenue code. Then you have to have a G code. The G code is what's going to trigger your payment for your FQAC. Here's your first G code, G0466. This is the code for a new patient visit. So, and I'm going to pause on this because the definition for Medicare FQAC new patient is different from the American Medical Association's definition for a new patient. A new patient is any patient that hasn't had any services in the last 3 years at the health center. So any medical services. So if they had a behavioral health or a medical visit within the last 3 years, they're not considered a new patient. Whereas if outside of FQAC, it's by the specialty. So if you hadn't had any new behavioral health visits and you came in for a behavioral health visit, you'll be a new patient. But it's different from Medicare. So it's any medical services within the last 3 years. So make sure you have something in place so that you're billing Medicare for the actual new patients that haven't had any medical or behavioral health visits in the last 3 years. So this is definitely very tricky. So the G046, that's triggering the payment, but in order to trigger the payment, you have to have a qualifying visit. So a qualifying visit this is what the doctor is going to document what they do to the patient. And the qualifying visit connected with the G0466 are these qualifying visits here. So in order to get paid for a new visit, you'll have to put one of these qualifying visits on your claim with the G0466. Now, G467 is for an established visit. So that's saying that a patient has had a behavioral health or medical visit within the past 3 years. And here's a list of some of the qualifying visits for an established patient. Next, we're going to go to the preventive visits, the IPP, or the annual wellness visits. And just have the codes on there. And you can't bill for an IPPE and an AWV in the same year. It has to be one or the other. And here are the qualifying visits for the preventive services for a new patient. Okay, and now here we go to the mental health, G0469. So this you'll use with the 900 revenue cycle code and the 469 for a mental health new patient visit. Now let's look at the qualifying visits for a 469. Here are the qualifying mental health visits for Medicare. So these are the mental health qualifying visits for the mental health to trigger a mental health payment for Medicare. For a new patient, now let's go for the established, G0470, for a mental health established patient. Now let's look at the qualifying visits for an established. So 90791 to 90845. Now, you guys know something interesting about the qualifying visits for an established mental health visit and for a new mental health visit? They're the exact same codes. So that's another thing where you need to have something in place to make sure you're properly billing for a new and established patient in your health center, because the provider is going to document based on American Medical Association guidelines. So you need to set up your system for the billing guidelines to make sure that you're billing appropriately. And as I say, they don't teach providers how to code and bill in school, so you need to have things in place as best as possible to make it as easy as possible for you and your organization and for the providers. Now, I put a link for I put a couple of the qualifying visits in there, but here's a link of all the complete qualifying visits for all the different G codes there. So make sure you have someone in your staff looking at this and make sure that that's updated into your system. Okay, so I know I'm keep saying this, but I know it's just a compliance. It's just a compliance issue, and it's definitely a concern. Make sure you have clear definitions on new and established patients. And when in doubt, just bill for an established patient, because it's better to not get to underbill than overbill, to get paid less than to get paid more than you're not supposed to get billed. But just make sure that there's someone in your organization responsible and making sure that everything is being built out appropriately. Okay, now, so I mentioned earlier that Medicare will pay you for your G code, your calculated PPS rate or your G code, whichever is less. So you need to set your rate for your G code. And let's talk about setting your rate for your fee schedule across the board. You need to have a methodology on how you set your fee schedule. In the compliance manual, in Chapter 16, it says your fee schedule needs to reflect reasonable costs, and you need to charge market rate for your services. So you have to look at your fee schedule, make sure that it's covering your costs, and you are covering your market, that you're being competitive. So that's for your overall fee schedule. But your G codes, this is a special payment trigger for Medicare. Your G codes and Medicare regulation says that the charge on your G code should represent the typical bundle of services for your Medicare patients. And what does that mean? Well, it can mean several things, but you need to have that conversation with your medical director on the typical bundle of services for your Medicare patients and set your G code appropriately. Now, that could be looking at your cost report and looking at your average cost per visit for your cost report and saying, this is going to be our cost for our G code. Or it could be, typically when our Medicare patients come in, they're a 99214, and they typically get a lab, and they typically get a flu shot and a pneumonia shot. And we bundle those charges together, and this is what our G code is. But whatever it is, you need to have it documented, and you need to have a methodology on how you set that G code. And I would say have a policy on how you set your G code, then have the policy on how you set your overall fee schedule, and then look at those and update those regularly. So that's very important for you to do that and to review that. And I'm gonna see if I can launch this next poll. Let me see. Let me stop sharing that. So as I'm gonna build this poll in. Well, actually, you guys can just put it in a chat. When was the last time your Medicare PPS rate for your G codes have been evaluated? Or have you even looked at your Medicare? So we can just use the chat function on there. And when was the last time that you looked at your Medicare PPS rate and when it was evaluated? And I love that annually, because that is definitely best practices to look at that at least annually. See some of the. Okay, so Julie's going through that right now and looking at an advisor. So Julie, let me know if you guys need any help on that, definitely. And definitely at least annually looking at that. So I would say, you don't have to necessarily change it, but just evaluate it. Looking at your fee schedule, looking at your G codes, and looking at your sliding fee discounts. I think all those in your federal poverty guidelines, that should be on your calendar at least every year to look at all those things that at least one time a year, because they all relate to each other. So looking at all at the same time will give you a good picture of that. Okay. So, all right. Thank you guys so much for those responses. I appreciate that. So let me close down my chat window. Okay. So I'm actually coming towards the end of my content, and I'm going a lot faster than I expected. So I'm going to briefly talk about telehealth through the public health emergency. Now, CMS is going to give us, I do believe, a 60-day warning before they close the public health emergency. So right now, during a public health emergency for telehealth, we can get reimbursed as a distance site provider, you know, by providing face-to-face telehealth communication using real-time, face-to-face, audio-visual, and some audio-only telehealth services. So before the public health emergency, health centers could only be the originating site, meaning the patient could come in, but then we'll telehealth with a distant provider, but all we could get was like it was less than $30 for that visit. So a lot of health centers didn't engage in that because it really just wasn't worth it. But with the whole pandemic, they eased up the restrictions, so we're able to do telehealth as a distance provider and got roughly around $100 for that encounter rate. So it made it a little bit more lucrative for health centers to do it. Okay, so here's some of the definitions. So before we were just a originating site, but with the public health, we can now be a distance site. So we can, go ahead and build those providers and get that reimbursement. That all started in March of 2020. It's crazy now that it's 2022, and it's going on with the whole with the public health. There are some signs that we might be coming down towards the end of this, but they will give us a notice. But you need to have things in place on once the public health emergency ends, what's going to be your telehealth of the future and how you're going to move forward with that. So this is the way that you're billing for telehealth services now, using the 521 code if it's a medical visit, and then the G2025. The modifier 95 is optional. The list of all the telehealth services that you can provide is on the link here below during the public health emergency as a FQHC. So here's some other flexibilities. As of March 1st, these audio-only services, we are definitely campaigning on a national level to keep the audio-only services in place, especially for Medicare beneficiaries. We've had calls with CMS to say the population that Medicare serves shows that we need audio-only calls. I was like, it's great care because definitely for behavioral health, we saw the increase in quality of care using audio-only visits. And then a lot of the Medicare patients, they don't have a laptop with audio-visual or a smartphone with the camera and things like that. So this just this improves access for the actual demographics that Medicare is covering. So we're definitely advocating to keep these flexibilities in place permanently. But in order for that to happen, it will take an act of Congress in order to change that. So it is a big lift, and we're trying to do that, and we're advocating that on a day-to-day basis. The reimbursement for telehealth, it's not as good as a PPS during a public health emergency. It's $97.24, but it's definitely better than the $20 you got when we were just the originating site telehealth provider. Now, I talked about setting the G codes, the G0466 to the G0470. Now, you also need to set a rate for your G2025 for your telehealth visits, because they're going to pay you the $97.24 or whatever charge you have set for your G2025, whichever is less. And like I said, for your other G codes, you have to have a methodology for that and have it in place in your file. So ongoing considerations, this is actually, I have some additional slides on here. I'm sure Gerard's going to send the slides out to you there, just for informational purposes on other reimbursement you can get outside of your PPS rate. But in ongoing considerations, evaluate your fee schedule and services rendered regularly, code and accuracy, make sure that you provide you give your providers coding and documentation training, and then make sure that you're checked to make sure they're accurate. Definitely do outreach around IPPEs and AW annual wellness visits. And there should be someone on your staff who is your CMS champion who has that page benchmarked on their computer, and they check that at least regularly. I wouldn't say like every week, but I would say at least monthly, because things change, things are updated. One thing I do want to add in, one change for the Medicare FQACs for 2022, I didn't put in here. They did include, you can get Medicare PPS for mental health telehealth visits. And I'll get that information. I'll put that in the NoddlePod community for you guys. So that is something, and that's not tied to the public health emergency. That's standalone. So that's kind of like a little carve out. So hopefully from them doing that they're going to go ahead and move forward and make sure that we're permanent, that we're put in place as a permanent provider as a distance site provider for telehealth in the future, and get our PPS rate for that, and not the $97.24. And with that was a lot. Let me see. Do you have any questions, Gerard? I have a couple more informational slides, Gerard. We have about 30 more minutes. Do you want to go through your mentor response?
Yeah, why don't we have a mentor response, and then certainly if you want to, we have some additional time, we feel free to share the informational slides, Javine. So thank you so much for Javine. We appreciate you doing that walkthrough for us of the revenue cycle. Quite a few updates there, so I'm sure folks appreciate that. Our mentor reaction today is going to be provided by Georgette Dukes McAllister, our CFO lead mentor. So without further ado, I'm going to actually stop sharing here for a moment, and we'll give our attention to Georgette.
Good afternoon, everyone. Javine, once again, great information for us all. I'm going to start with the Medicare portion. A CMS champion. Wow, that is a great idea. With the ever-evolving changes that CMS brings down, what better position should we have but a CMS champion that's riding it, making sure that we're up to date on everything and making sure that we're staying knowledgeable on all the changes. I'm glad to hear about the advocacy that NAC is doing for Medicare. Maybe that's something that the CMS championship can help you guys with as well. You know, the complexity of rate setting, it's always great, and I encourage everyone, as Javine said, have your G-code policy and your rate setting policy available at all times, and make sure you're following, what that policy is in place. And as Javine mentioned, 3 things you definitely need to look at annually: the fee schedule, your sliding fee discount, and your G codes. Those are definitely need to be looked at and evaluated on an annual basis, and they all do interrelate. So with access to telehealth, it's going to be important that we stay on top of that, making sure that telehealth continues to be part of our future. Okay. And regarding the revenue cycle and its simplicity, Jermaine, I think you communicated that it's the cycle that describes and explains the life cycle of a patient through a typical healthcare encounter, from pre-registration to final payment. And that's important, not just for the finance team to hear, but everyone in the organization needs to hear that message. That should be part of your onboarding procedure, to let everyone know where they fall in the revenue cycle. Okay. Following best practices, I'm glad to see that she put in there about communication, because words do matter. When I looked at the slide with how the front desk asks questions and how they should say things and how they don't say things, it really drives whether or not you're going to set the patient up for success or just let them think that you really don't care about if they come in or not. Quick story, I called the health center to see about their appointment scheduling a couple weeks ago. And I said, well, how soon can I get an appointment for a physical? They say, well, if you really want to know, it'll take 2 weeks for you to get a physical to come in just to find out what kind of insurance you have. Then it'll take 2 more weeks to get a telephone call. I'm like, I can't believe this is how people are being trained, or if they're even being trained. So you have to make sure we're training that front desk staff to be part of that communication. Also, like you said, your physicians, make sure they get annual training on coding as well. It's a whole team effort for revenue cycle, and you can be a success making sure that you communicate with everyone. That's the message I got from Javine. Thank you.
And you know,
Thank
I
you
just
very
thought,
Go ahead, Javine.
I thought of something I was going to add about telehealth. So, and you, Georgette, when you said making telehealth part of our future, it sparked my mind on this. When you're budgeting, I mean, you guys need to sit down with the CFO and the CMO saying, when do we need to bring the patient in, and when is a telehealth visit appropriate? And you need to look at that patient paneling and budget appropriately, because they don't need to come in every time. And a lot of the patients, they like doing the telehealth visit. So if you say all of a sudden now you need to come in every time, they're going to be like, well, why? So you need to have a good reason. It's like, you're diabetic, so once a year we need to have you come in so we can do your blood draws and check your feet. But the other times you can do telehealth visits. That totally changes the conversation. So in budgeting and things like that, these are the conversations that we're going to have now post-pandemic that we didn't have previously in preparing. And then making sure you have all the resources and things like that, resources you have in order to be successful. And then also cybersecurity. I know a lot of people working from home right now. So if you have your billers working from home, make sure that it's locked down, not only, from what they're accessing, but then their family. Make sure that they sign an agreement to say they're not going to let their family look and see that PHE. Because, if they're sitting up on, they have their computer on, and someone walks by and sees someone's information, that's a liability. So I'm throwing I'm throwing all the stuff, because Georgette just made me start thinking about all these different things that I didn't touch on yet. And then the last thing, there's a No Surprise Billing Act, and we're going to put some resources out from NAC. I'm waiting for it to get approved by CMS. The No Surprise Billing Act pretty much says that you need to let the patient know how much they're going to have to pay for their visit before you provide care if they schedule a visit. It's very complicated. We're trying to get some resources, but you need to be aware of that and just keep, and I will add that into the Nautipod community as well, but it's something you need to be aware of. And that's all I have, Gerard. And thank you guys so much for all the good work you do out there in the field.
Thank you very much, Javine. Again, we appreciate you sharing this helpful information for us, and thank you for your insights and reflections on that, Georgette. Are there any questions for Javine? If you have questions for Javine, please feel free to either
unmute yourself.
Yeah, unmute yourself and speak your question, or post those questions in the chat, whichever is most comfortable for you. But this is an opportunity to ask any questions that you might have.
And I'm going to put my email in the chat. So if you guys have any questions or any concerns about the No Surprise Billing Act or anything I commented today or talked about, I'm a resource. Gerard and I are here to support you guys out in the field. That's what we're here for. And we're successful when we help make you successful. So don't hesitate to let us know if something we can do to help you guys.
Thank you, Javine. Are there any questions? Any questions?
Okay,
questions.
you mentioned
ahead.
good faith estimates. Is there any update on future clarifications on the GFEs to exclude FQHCs? So that's a great question. So we did do a comment letter about the good faith estimate. We didn't try to get an exclusion for the FQHCs because this is good for the patients, and as a safety net provider, it will be hard for us to try to be exempt for something that's good for the patients. But what we're trying to do is show that we are a step ahead of all the other healthcare providers because we have the sliding fee discounts, because we make sure we give patients access to care regardless of their ability to pay. So we're trying to work around it a different way. I don't think we're going to get an exemption from it, but we're going to try to paint our picture and show that we are definitely more responsible than a lot of the other providers out there. But great question, Cindy.
And I see another question there as well, Javine, about imaging services.
Okay. So the professional fee we're talking about for Medicare. The professional fee is included in your Medicare PPS rate, but you can bill Medicare Part B for the technical component. So that's the processing of that lab or that X-ray. So great question.
Right. Thank you, Cindy and David, for your questions. Any additional questions before we move to what's coming up next? Before we move to what's next in line for the Leadership Institute. All right. Well, thank you again, Javine, and thank you all for your questions. I'm going to pull the slides back up here and want to highlight, you all received a message from me earlier today about, we move, there we are. You all received the message from me earlier today relative to the wrap-up session with registration and lodging details for that. We ask that you please go ahead and register for the wrap-up session on Tuesday, May 10th. It is a full day session. And we ask, I think, that you register by the end of March, and that I think the closing date for lodging for the hotel in Alexandria, Virginia is April 12th or somewhere about there, or until the block closes. So we ask that you go ahead and register and make your hotel reservations as soon as possible. Next up, in just a couple of weeks, so we've got on the 22nd, our next session on strategic use of data with Jonathan Chapman from Capital Link. So that is always a very content-rich session as well. So we'll look forward to having you back with us to meet with Jonathan Chapman in just 2 weeks from today. Please continue to engage with your mentor groups. I am going to send out an updated capstone project instruction sheet. A couple of you have asked, are we assigned to the same number that we were previously, or is it based on our name and the like? So I will clear up that confusion for you. The mentor name that was assigned to the specific area of focus will still be the same for you for your assignment. But I realized that when we put that together, it was before we had some of the mentors come on board. So their names have been added, and I've updated it based on the numbers, the number for your mentor group. So I'll post that in Nautopod, and I'll add it to the calendar appointment later today for you. The new due date for having you submit those capstone projects is going to be May the 3rd, so a week before the session. That'll give us a chance to sort of look through them and give us the opportunity to prepare to inform those of you who will be presenting at the session. So everybody should be prepared to present in that at the closing event, but recognizing that we're going to select five of your groups to present. So it'll be you'll be anxious right up until the last moment. But we know you'll all be well prepared and looking forward to sharing what you've learned over the course of the Institute with your colleagues. So with that said, please complete the session evaluation. We'll give you, I guess, about a good 25 minutes or so back into your day-to-day. So make the most of them, and we'll look forward to, Javine, you want to add something before we wrap up?
Yeah, I just put into the chat, I'm just launching my Revenue Cycle Learning Collaborative. So if anyone's interested, you guys got the first access. It's going to be limited to 25 people. So I put the brochure and the actual link in order to apply. So if you want to go even deeper into what we did today.
Thank you very much, Javine. You guys got first dibs. So if you're interested, please go ahead and apply for that. All right. With that being said, I think we'll bring it to a close today. We'll see you guys in 2 weeks. Take care, everyone. Thanks again, Javine.
Thank you. Thanks for the opportunity, Gerard. I appreciate it.